Welcome to another MedNexus Explainer. Today, we're diving into a fascinating and honestly totally crucial topic in immunology and pathology. We're going to look closely at a phenomenon that turns our body's ultimate protectors into a significant internal threat.
I mean, it's a pretty dramatic scenario, right? Think about it. What actually happens when your immune system suddenly decides your body's own cells are the enemy? Out of nowhere, red blood cells are getting destroyed, platelets just vanish, and vital cellular receptors, well, they become the targets of some serious friendly fire. This is the core mystery of type 2 hypersensitivity. It's an antibody-mediated reaction that is literally responsible for some of the most critical autoimmune and transfusion-related diseases we see on the wards.
Okay, let's dive into this. Here's our roadmap for today. We'll start with when immunity attacks itself. Look at the 3 mechanisms of injury, step onto the clinical battlefield, run through diagnosis and treatment, and finally, wrap it all up with a high-yield exam review.
Section 1. When immunity attacks itself. Let's clearly establish what we're actually dealing with here. So, type 2 hypersensitivity is specifically an antibody-mediated immune reaction. This kicks off when rogue antibodies lock onto antigens that are basically fixed in place. They're scanning for antigens right on cell surfaces, clinging to the extracellular matrix, or sitting directly on tissue receptors. And the ultimate outcome of this targeting? It's severe, guys. We're talking direct cell destruction, massive inflammation, or just completely abnormal cellular function. Now, the primary weapons of choice here? That would be IgG and IgM antibodies. They're the ones locking onto the host's own cells, or the extracellular matrix. Now, take a look at the bottom points here because this is highly testable. Unlike the immediate allergic reactions you might be thinking of, IgE antibodies are absolutely not central here. And mast cells? Also not the primary drivers. For type 2, you've got to keep your focus strictly on IgG and IgM.
Moving on to Section 2, 3 mechanisms of injury. We know who's attacking, so let's break down exactly how they deal their damage, using the rule of 3.
First up, we have straight-up cell destruction. It goes like this. Step 1, IgG or IgM antibodies bind directly to antigens on a target cell surface. Step 2, this binding basically acts like a massive flare gun, activating the complement cascade. And step 3, this complement activation triggers a really aggressive 3-pronged assault. You get opsonization, which tags the cell to be eaten, phagocytosis, where macrophages literally consume the cell, and direct cell lysis, where the cell membrane is just blown completely apart.
The second mechanism shifts our focus from floating cells to solid ground, inflammation. In this scenario, the rogue antibodies deposit directly into fixed tissues, like your basement membranes. Just like before, complement activation fires up right at the site of the deposition. But instead of just taking out a single cell, this activation acts as a giant beacon. It recruits inflammatory cells, particularly neutrophils. These neutrophils swarm in, release their enzymes, and cause some truly severe, localized tissue injury.
And this brings us to the third mechanism, receptor dysfunction. This is where things get really fascinating, honestly, because the cell isn't actually destroyed, it's hijacked. On the left side, antibodies are binding to receptors and actually stimulating them. They're mimicking the body's natural signals and driving excess cellular activity. On the flip side, over on the right, they bind to receptors and just block them entirely. They stop the normal chemical messengers from doing their job, which completely shuts down normal function.
Section 3, the clinical battlefield. It's time to take these mechanisms and see how they actually show up in our patients. Let's check out the blood cell casualties first, which ties right back into our first mechanism of cell destruction. First up is autoimmune hemolytic anemia. This is where the body's own red blood cells are targeted, giving us those classic clinical signs like pallor, profound fatigue, and jaundice as the cells break down. Next is the hemolytic transfusion reaction. If a patient gets mismatched blood, pre-existing antibodies trigger a rapid, totally life-threatening destruction of those new RBCs. And finally, there's hemolytic disease of the newborn, a critical situation where maternal anti-Rh antibodies cross the placenta and launch a devastating attack on the developing fetus's red blood cells. Now, moving from free-floating cells to solid tissues, we see our second mechanism, inflammation, in action. The absolute textbook example for this is good pasture syndrome. Here, the rogue antibodies are specifically hunting down basement membranes, but they have a very strict preference. They go after the lungs, causing patients to cough up blood, which is hemoptysis, and the kidneys, which leads to a really destructive glomerulonephritis.
It's basically the perfect example of neutrophil-mediated inflammatory tissue injury.
So what does receptor dysfunction actually look like in a patient? Well, it couldn't be starker than the contrast you see right here. For the stimulation side, we've got Graves' disease. This is where antibodies stimulate the TSH receptors on the thyroid gland. It's like they've jammed the accelerator to the floor, causing massive hyperthyroidism. Think weight loss, a racing heart, exophthalmos. Then on the blockade side, myasthenia gravis. Here, antibodies are blocking the acetylcholine receptors right at the neuromuscular junction. The signal to move just never makes it through, which leaves the patient with profound, fatigable muscle weakness, like drooping eyelids and double vision. One stimulates, one blocks, but they are both type 2.
Section 4. Diagnosis and treatments. Let's figure out how we actually identify this friendly fire, and more importantly, how we stop it. To catch these culprits, the lab is absolutely your best friend. The gold standard that you absolutely must remember is the Coombs test. It is crucial for diagnosing those red blood cell destruction conditions we just talked about, like autoimmune hemolytic anemia and hemolytic disease of the newborn. Now, for the other conditions, we lean on highly specific autoantibody detection. Suspect Graves? You look for anti-TSH receptor antibodies. Suspect myasthenia gravis? You're going to screen for anti-acetylcholine receptor antibodies.
Once we've got the diagnosis, stopping the attack usually means we have to turn down the volume on the immune system. We use immunosuppression, relying on the mainstays like corticosteroids, targeted therapies like rituximab, and other immunomodulators. Now, if we need immediate physical removal of the threat, we go with plasmapheresis. This procedure literally filters the patient's blood to pull out those circulating IgG and IgM antibodies. It's a lifesaver in acute crises of myasthenia gravis or Goodpasture syndrome. And, of course, we use disease-specific therapies to handle the fallout, like antithyroid drugs to cool down the thyroid in Graves or careful transfusion support for severe anemia.
Section 5. High-Yield Exam Review. For all my MBBS students and NEET PG aspirants tuning in, grab your notebooks. This is the home stretch.
Let's build a quick comparative framework because test writers love, and I mean love, to make you differentiate between hypersensitivity types. Type 1 is your immediate allergy. It's mediated by IgE, mast cells, and histamine release, resulting in things like anaphylaxis. Type 2, as we've hammered home today, is a completely different beast. It is strictly mediated by IgG and IgM, it's cytotoxic or tissue-specific, it heavily relies on complement activation, and it causes diseases like hemolytic anemia. You've got to keep these crystal clear in your mind. Okay, here are your rapid-fire, absolute must-know exam points. Lock these in. Type 2 is strictly antibody-mediated by IgG and IgM. The tissue injury you see is overwhelmingly driven by complement activation. When it comes to receptors, Graves equals stimulation, myasthenia gravis equals blockade. If a question describes antibodies targeting the basement membrane of the lungs and kidneys, your brain should immediately scream Goodpasture. And finally, diagnosing an immune-mediated hemolytic anemia, you order the Coombs test every single time. And to guarantee you never ever blank on the primary culprits on test day, use this super simple memory trick. Type 2. Just picture the Roman numeral 2 in your head. Let those two vertical lines remind you of the two primary antibodies, IgG and IgM. Type 2 equals two antibodies attacking tissues. It's simple, it's highly effective, and I promise you it will save you points on exam day. It really leaves you with a profound sense of awe for human biology, doesn't it? When our ultimate protectors, these incredibly complex antibodies, become our greatest internal threats, you really have to wonder, just how delicate is the balance of the immune system? It's this razor-thin wire between robust health and devastating disease. Well, thank you so much for joining me for this MedNexus Explainer. If this helps click things into place for your studies, definitely share it with your fellow medical students. Until next time, keep learning and stay curious.